so somewhat of a change in focus really here, from right inside the heart of the pathogen to starting to look at the impact of COVID across populations, and particularly to think about inequalities in how COVID has affected different parts of the population. And you'll see I have the wrong pandemic here, but this is, I think, really just to remind us that although things are terrible, they could have been a lot worse when we consider the number of deaths that were related to the 1918 pandemic. Some estimates are up to 50 million, despite the global population being 5 times smaller than today. You realize what a potential huge catastrophic devastation respiratory viruses can cause, which is why I've been interested in them through my career as an infectious disease epidemiologist. But I'm also, the other part of my research is really focusing on inequalities, and particularly extreme inequalities. So naturally, when given the opportunity to talk to you, I thought I'd try and merge those concepts. It's hard to think back that it's little over a year ago that we've started to hear the first reports of COVID-19. And I remember hearing those really quite early on, because I was a member of our committee called the New and Emerging Respiratory Virus Threats Advisory Group, which was really needing to form assessments of the potential threat of this virus. And it's been a learning experience ever since. So this is just highlighting the number of global cases, which of course is a big underestimate, as well as the number of global deaths, which will also be a big underestimate, and showing the countries in the world with the highest numeric numbers. Of course, those numeric numbers of cases are a bit misleading in terms of they give no account of the size of those populations. And unfortunately, when we look at the United Kingdom, we're in the unenviable position of having had amongst the highest disease and death rates in the world. But I think one of the things to me that was quite a big surprise about COVID, when you think of so many diseases are so graded globally according to the level of poverty globally, that COVID has just not really been like that. So this plots the per capita income against the per capita death rate, and we can see very clearly that it's the tends to be the richer OECD countries, industrialized nations that have been most affected by COVID, with a few notable exceptions which have managed to implement very rigorous control measures early on, whereas poorer parts of the world have generally been less affected. So you could, in that sense, say that COVID has somehow reduced global health inequalities at the expense of worsening the health of the richer countries. So of course, the pandemic has also had an enormous impact on employment. This is from the International Labour Organization. Their estimates of the number of employment losses during the pandemic, which peaked at about 144 million lost jobs. So that's, I guess that's 70 jobs per death or something like that. But we can also see that some of that job losses have started to be recovered already, but really an unprecedented impact on employment. What this map shows is the percentage of work hours lost due to the pandemic, and overall internationally that's around 23% of work hours have been lost to the pandemic. I'm sure many of us on this call will be feeling they've made up quite a lot of those hours and have been working harder than ever. But across the population, this is 4 times higher impact on working hours than the 2009 economic crisis. And there's nothing really comparable to it since the Great Depression of the 1930s. But again, we can see that the countries that have the highest loss of working hours are the same countries that have the highest rates of COVID. And this, again, is really sort of reinforcing that, and it's looking at the correlation between the death rate in a country and the effect on the GDP. So the percentage decrease in GDP that countries have seen. And again, we can see that it's the richer countries that have been hardest hit economically, and those countries that have managed to maintain relatively low levels of COVID have had relatively minimal economic impact. This figure is, so whilst we think about the international context of COVID inequalities and how, in a sense, they're working in the opposite direction to normal, within country, the picture's very, very different. And so this picture is really trying to illustrate this convergence of risk factors. So social inequalities and ethnic minority inequalities are linked to concepts like overcrowding, multi-generational households, people in those groups also being much less likely to be able to work from home, they'd be more likely to be using public or shared transport, and have the sorts of occupations where they maybe have high levels of exposure to the public, or indeed in healthcare, which in turn leads to high infection rates. But because this is a dynamic disease, they'll be returning to their communities with those high infection rates, which will further drive this cycle of inequalities and mortality differentials between different ethnic groups, different social groups. This is a report from Professor Sir Michael Marmot, who some of you may know as a very influential international figure in the field of health inequalities. I'm proud to have him working in our institute at UCL. He recently did a report on health inequalities, which got, he said, 85 million tweet impressions, which he was quite pleased with. And he was rather disappointed that this one that was specifically about health inequalities in COVID has only had 5 million so far. So if you look it up and tweet it, he'll be very pleased. But anyway, this really summarized the evidence in the UK context about the unequal distribution of the impact of COVID. And I'll give you some highlights from it and other analyses. So what this graph is doing is it's dividing every area in England according to the level of social deprivation. So with the poorest areas on the right-hand side and the richest areas on the left-hand side. And we can see this really marked social gradient in COVID, as we see for many diseases, most diseases, in fact. And we're seeing approximately a 2.5-fold difference between mortality rates in the poorest areas of the country compared to the richest areas of the country. This is dividing those area level deprivations in the population into essentially quintiles, 5 groups, with quintile 1 being the most socially deprived and quintile 5 being the least socially deprived, and looking at the differential COVID rates during the first wave of the pandemic. And I think the really interesting thing to see here is that they started off fairly even. In fact, if anything, it was the richer people who had slightly higher rates at the beginning of the pandemic, presumably because it was those groups who were more able to travel. But as we move into high levels of restriction and lockdown, where we've got more of a division between those people who can stay at home and work safely from home and those who can't, I think what we're beginning to see is a widening of the inequalities as the lockdown takes place and the pandemic peaks. And we see exactly the same sort of pattern with mortality from COVID, with that widening of inequalities during the lockdown. So in some senses, you could think about this as an intervention-induced inequality, which is allowing some people to protect themselves and other people's not. This is a figure looking at the age-standardized mortality rates amongst males and females according to different ethnic groups. And I think people were really shocked here at the extent of the differences in mortality rates across different ethnic groups. I think it shone a really bright light on the inequalities in our society. A lot of this was sort of coinciding with so many of the concerns about Black Lives Matter. And here we can see a really shocking, again, to more than twofold, 2 or 3-fold difference in mortality rates, for example, between the Black African ethnic groups and the white ethnic groups. And again, this is of course intertwined with those issues of poverty and occupation and overcrowding. This graph is really plotting the percentage of households that are overcrowded in particular neighborhoods with the COVID death rate. And we can see once we start to get into a reasonable percentage of overcrowded households, we can start to see that association. And for those of you who are familiar with the UK, you'll realize the names of these places are also places with high BME populations within them. So, so high levels of overcrowding in those areas. And then what this graph is pointing at is again showing from the richest areas on the right-hand side with a very low percentage of households that are overcrowded to a much higher percentage in the poorest areas. But it also, it looks at whether or not those households have a vulnerable person in them, either an elderly person in them or somebody with a chronic illness. So not only have you got more overcrowding, but when people are coming back to overcrowded households, they're more likely to be exposing someone who's highly vulnerable to getting severe disease. This is a plot I did based on age standardized mortality rates. But looking at, there were surveys during the first wave of the pandemic about what percentage of people did at least some work from home in different occupational categories. And so you can see on the right-hand side, the professions where a high proportion of people were able to work from home, as you'd be unsurprised, they're sort of professional occupations, managers, directors, essentially white collar and some technical jobs, and their mortality rates being from COVID being substantially lower than the mortality rates of people who could very rarely work from home. So people working in factories, people working in caring and other occupations, trade workers, and people working in retail, for example. And you can also see there are scales of occupational proximity, which is essentially how close do you have to come to other people in the course of your job. And if you relate those to the COVID mortality rates, again, you see higher rates of mortality according to occupational proximity. This graph is, apologies, it's somewhat complicated, but essentially it's showing on the left-hand side across major occupational groupings, the age standardized mortality rates in men, and we can see that difference that we were showing early on with the essentially divide between those who can work from home a lot and those who can't. But then when you look down at individual occupations, you see some really quite pronounced differences in mortality. And aside from the obvious, where you would expect, healthcare workers and people working within nursing homes, for example, and social care workers to have high rates of COVID mortality, we also see pronounced increases in risk for people who are essentially working in factories or warehouses, people driving buses or taxis, so in confined airspaces with members of the general population, people working in sales and retail roles, as well as people working in things like food processing plants. So again, occupation, a big driver of mortality, and we see similar but not quite equivalent patterns in females, where of course overall mortality rates are lower. And if we look internationally, we see similar patterns to that. For example, there's been a very good study of that from California, looking at occupational mortality. One of the things, of course, it's not only the different impact of the virus on mortality and disease levels, there's a very differential impact of the control measures on people, starting right from childhood. And this was really a graph showing the very different educational experience that people will have had according to the wealth of the areas that they live in. And so people living in wealthier areas were far more likely to have meaningful online face-to-face education classes when schools were shut down than people living in the poorer areas. And so we're seeing a real exacerbation of those early life inequalities and educational differences. And the other thing, when we look at the sectors of our economy that were shut down, those areas that were shut down tended to have a disproportionate amount of young people working in them. So working in the hospitality industry and non-essential retail, for example, a lot of young workers becoming unemployed. And similarly, when you look at the shut down sectors, it tended to be sectors with low paid workers. So the pattern we're really seeing is a really differential impact on those people who can least afford to lose income. And when we look at this internationally, this is the changes in employment according to the skill levels of the workers. And again, we can see that for the professional classes, managerial classes, there's really been no impact. But when you get down to low skilled work, there's been a big impact on levels of employment. This is an interesting graph, which if we focus on the right hand side, where we can see both the United Kingdom and the USA, essentially what it's showing with the red bars is the reduction in working hours, which has been relatively similar in the UK and the US. Whereas if you look at the reduction in income in the dark blue bar and the change in employment rates, that's been substantially lower in the UK than it has in the US, because we've had a very active program of supporting employers to continue to pay people even when their businesses have needed to be shut. And I think that's probably been much less extensive under the Trump regime, but it was very heartening to see the sort of stimulus package that's being proposed by Biden. And again, this is data from the United States, which is looking at the effect on employment in men and women you can see that dip in employment towards the coinciding with the pandemic. But what you can see here is that dip in employment is really much more marked in those with low educational levels, and it's much more marked in non-white ethnic groups. One of the areas that I did a lot of work on earlier in the pandemic was the potential impact of COVID in in the homeless populations, which of course represent the extreme end of social deprivation. And we were very worried that the convergence of high levels of comorbidity and high levels of living in communal settings, in dormitory style night shelters, would lead to explosive outbreaks. And this slide just shows how around many parts of the world, indeed, we did see explosive outbreaks with high attack rates and high mortality rates in homeless populations. And this is data from France among people screened in emergency shelters, showing that about 50 or 60% of them were seropositive for COVID. What we did in the UK, we managed to convince the government that it would be a good idea to move everybody who was using these night shelters or sleeping on the streets into disused hotel accommodation, and managed to house about 35,000 homeless people that way. And this is a model that we did looking at the impact of that on COVID-related deaths and infections. And overall, we modeled that approach, combined with infection control in existing hostels and outreach of testing, etc., led to a substantial decrease in infections and hospitalizations and ICU admissions and deaths. But we hypothesized that if those measures were not continued, we would see a big wave over the winter. And sure enough, actually, a lot of those measures have been rolled back in the second wave. So many of those emergency hotels have been shut, and the people who were in them were being put back into the existing hostel provisions so that it becomes much more overcrowded, which combined with a more transmissible strain means that we've been doing outreach testing across London, and you can see we've had a very different epidemiological picture amongst the homeless in this second wave of the pandemic than in the first. I'll skip over these slides, but obviously one of the highlights of the pandemic is the speed with which we've been able to develop effective vaccines. But I think when we think about inequalities, we have to think about inequalities in vaccine distribution. This is a map from a few weeks ago now of the vaccine doses administered in different parts of the world. And we can see many parts of the world have yet to even start. And I think this is going to become a huge global inequality, the speed with which we can deliver vaccinations. Obviously, the COVAX WHO project to try and get governments to invest in vaccination around the world is really critical to this. But I thought it was also salutary to think this report from Oxfam, one of our global charities, suggesting that the rise in wealth of the world's 10 richest men during the pandemic could pay for vaccines for the whole world. So I think we also need to think about the role of philanthropy in increasing vaccines. And of course, when we do roll out vaccines across the world, we need to think about those inequalities that I've just described in how we roll out vaccines. Generally speaking, most vaccine programs are initially focusing people in the highly clinically vulnerable groups, particularly the elderly. But I think somewhere along the line within the prioritization, we need to think of issues like poverty and occupation and ethnicity. Of course, the other big global inequality is really the level of vaccine hesitancy around the world, and that's very different. In the UK, we've got a high level of trust in vaccines, a bit less in the USA, but markedly less in some parts of the world. And of course, that's not helped by anti-vaccine lobbies, and this is some we think sort of Russian propaganda about the AstraZeneca vaccine. And we have particular issues with low levels of communities that have low levels of trust within the government, maybe for good reason, also tend to have low levels of trust in the vaccine, and we're seeing much lower vaccine uptake rates across BAME communities, which of course are also the communities which we expect to be most affected by the pandemic. So we have, if you like, this inverse care law, and we really need to do much more to work with local communities to dispel myths and outreach vaccination to make it as convenient as possible in those areas for people to get vaccinated. This is really just, I hesitate to go into variants given the expertise on the panel so far on this, but I think this is just to remind us that it's a really tough job to stop variants spreading across the world. Short of closing our borders forever, then variants are going to spread, and there's something that we're going to need to come into to have to deal with. As sure as evolution works, new variants will arise under selective pressure. You know, they'll either be more transmissible or they'll be more able to evade the immune response. And sometimes as a sort of side effect of that, as we've seen in the British strain, they may also have higher mortality. So I think the basic message is that I think we're not, whilst we've got light at the end of the tunnel from this, we're still a long way to go before we're out of this. As we continue with our interventions on the way out, we need to think about how our interventions can tackle these really extreme health inequalities that we see in COVID. And I think there's a number of ways that we can do that through fiscal measures, through targeting of vaccine, through targeting of testing, through targeting of public health messaging. And so we need to do that, but also as we emerge from the pandemic, we need to be really thinking of building back fairer and dealing with some of these underlying and really awful inequalities that lead to these huge differences in death rates in the first place. So I'll leave it there.
Great. Thank you very much for that. I thought it was really interesting that the wealth inequalities maybe come down to the ability or the lack of ability of people to be able to self-quarantine, and the wealthy can do that, and the poor cannot. And
I think so. That, you know, there's this whole thing within the health equalities field about, you know, the level of agency that you have. You know, you have choice over your decisions when you're in a richer and privileged position, whereas despite, you know, in our government we have a lot of almost blame, if you like, about, you know, people not following the rules and things, but actually people don't necessarily really have that choice given the economic circumstances and level of power that they have.